Greetings to everyone. Today we are going to look at a very interesting topic, pertussis or whooping cough. You're welcome to our big class. Under this topic, we are going to look at the following: introduction, etiology, microbiology, pathogenesis, transmission, clinical presentation and risk factors or individuals that are at risk, and then laboratory diagnosis, treatment, complications. Under our introduction, pertussis is an acute bacterial respiratory infection characterized by an inspiratory whoop following paroxysmal cough. It's highly contagious with an incubation period of 7 to 10 days. Sydenham first used the term pertussis, meaning intense cough, in 1670. It is preferable to whooping cough because most infected individuals do not whoop. So it's preferable to call this infection pertussis because most of the individuals that get this do not whoop. And the etiology, the major etiology is Bacterial pertussis and is the cause of epidemic pertussis and the usual cause of sporadic pertussis. However, Bacterial pertussis is an occasional cause of sporadic pertussis that contributes significantly to the total cause or cases of pertussis in Eastern and Western Europe, but accounts for less than 5% of Bacterial isolates in the US. B. pertussis and B. parapertussis are exclusive pathogens of humans and some few primates. These particular species are small, they are gram-negative coccibacilli that colonize only ciliated epithelium. So they are going to colonize only the ciliated epithelium in an individual. The exact mechanism of disease symptomology remains unknown. However, these species share a high degree of DNA homology among virulence genes. The virulence genes that these species produce, they share part of their DNA. They have similar features in their DNA. But however, you should note that only B. pertussis expresses the pertussis toxin, which is the major virulence protein. The organism expresses a number of virulence proteins. We shall look at them in the following slides. These virulence factors are responsible for the clinical features of pertussis and the immunity by stimulating an immune response. Pertussis is primarily a toxin-mediated disease, so the effects as a result of the release of the pertussis toxin. The bacteria attach to the cilia of the respiratory epithelial cells, producing toxin that paralyze the cilia, because remember we have said they attack ciliated membranes or epithelia. Then, after paralyzing the cilia, they go ahead and cause the inflammation of the respiratory tract, hence allowing the invasion or the penetration of the toxin. The virulence factors now, when this organism enters into the body and reaches the respiratory tract, it has different proteins for three specific processes. One, the virulence factors for attachment to the ciliated respiratory membrane or epithelium. You have this majorly, we have filamentous hemagglutinins, then you have FIM type 2 and 3, and then pertactin. These proteins here are responsible for attachment. And after attachment, what happens? They are those virulence factors that are produced for inhibiting the clearance of the organism from the respiratory tract by the cilia. So you have tracheocytotoxin, adenylate cyclase, and pertussis toxins. This inhibit the clearance of the organism. Now it has attached. An individual has failed to clear this organism. What happens next? Now, what happens is local epithelial damage. So they damage the epithelia. So the proteins are responsible for damage of the epithelia are the tracheocytotoxins, the monocrotic factor, and adenylate cyclase. Hence, after damaging, you have easy penetration of the or absorption of the pertussis toxin. How is it transmitted? Pertussis is transmitted via nasopharyngeal and bronchial secretions. These are respiratory droplets from uninfected individuals or freshly contaminated fomites. Therefore, it's most contagious during the early catarrhal stage. We are going to look at the stages of the infection or how the progress of the disease. So it's very contagious in these early stages, and that is less or equal to 3 weeks. During this contagious stage, the secondary attack may be up to 90% of non-immune household contacts. If patients are untreated, they may remain contagious for less than or equal to 3 weeks following the onset of cough. So they will remain contagious from the onset of the cough up to around 3 weeks. But of course, if the individual is treated by 5 days, we are able to limit the ability of transmission of this infection. Now, however, what should know that the carriage state has not been described in humans. So, in the clinical features, classically, pertussis is divided into 3 stages. That is catarrhal, paroxysmal, and convalescent stage. Under the catarrhal stage, that is the first 1 to 2 weeks, it's associated with the following features: rhinorrhea, that's a runny nose, nasal congestion, you have sneezing, conjunctival suffusion, low grade fever, this can be mild, and a mild occasional cough. The cough gradually increases. So this cough is very mild, and sometimes it's even not there. So in this stage, you have features of a common cold. So you may confuse it with a common cold. This is after the onset of cough. Then, of course, you should also note that this happens after the incubation period of around 1 to 7 days. Then after you have onset of cough, and then you have this stage. Then the next stage is paroxysmal stage, which takes 2 to 6 weeks. Here you have more severe and frequent repetitive cough ending in a whoop. Also, you have pertussive emesis or vomiting. So this person is having severe cough, and at the end of that cough, they vomited. So I have conjunctival hemorrhage. Fever may be present, but patients become increasingly tired. In infants less than 6 months, however, here paroxysms lead to apnea, cyanosis, and the whoop may be absent in these infants. So the last stage, which is the convalescent stage, here you have the number, the severity and duration of the episodes diminish. We are meaning the cough episodes that used to be there and their severity now decrease. Yeah. Cough may be present in some cases. So, however, also there are these groups that may not necessarily follow the exact course of the dislike we have described, like infants less than 3 months old do not display the classical features. The catarrhal phase lasts only a few days or even might be unnoticed. Then after, you have more insignificant startle from drift, light, sound, suckling, or stretch. So you have a well appearing young infant begins to choke, they are gasping, they are gagging, and you're seeing they are folding their extremities. They flay the extremities, the legs. That should raise concern. Infant was well, but now they are unable to feed well. They are choking. Then, in adolescents and previously immunized children, they have forward shortening of all the stages of pertussis. And then in adults, adults also don't have distinct stages. Classically, adults describe a sudden feeling of strangulation followed by an interrupted cough, feeling of suffocation, bursting headache, diminished awareness, and then gasping breath. They are gasping for their breath, usually without a hope. See? Yeah. Then, therefore, note that in general, pertussis should be suspected in an individual who is febrile with increasing cough duration and severity. Signs and symptoms of pertussis may vary slightly between different age groups. Individuals at more risk, mostly the young, unimmunized infants less than 3 months of age, or those born to unimmunized mothers are at increased risk of severe or complicated pertussis. Then those partially immunized infants, if they have received less than 3 doses of the TAP, they are not fully protected. However, the disease severity may be reduced. So this is a summary of the cause of the disease, incubation period of say a week, yeah, it's 5 to 10 days, and then you have the onset of cough. You see the arrow there showing the onset. So if there is onset here, the first 1 to 2 weeks is catarrhal stage. Then from 2 weeks to around 8, that is the next stage, paroxysmal stage. And then, of course, this stage is the whereby you have a severity of the cough, the whooping, pertussis vomiting in this stage. Then you have convalescent stage from 8th, 12th week, and here you have the symptoms diminishing. Yeah, the frequency of the symptoms diminishing. However, above here, you should note that communicability, the ability of the ability of the disease to be transmitted from one individual to another is mostly, that is onset to 3 weeks. Yeah. All right. So let's look at how we diagnose. We diagnose this disease by combining clinical features with laboratory findings. The clinical features that we have seen above in the 3 different stages, there is a little highlight here. Clinically, pertussis should be suspected in an individual who has pure or predominant complaint of cough. Are you seeing? They're having predominant complaint of cough. However, the following features are absent. They don't have fever. They don't have malaise. They don't have sore throat, hoarseness, tachypnea, a wheeze or rails. Because these are features tend to be associated with pneumonia, for example. So they are not there, but someone is complaining of a cough. Then also in sporadic cases, also you have cough of 14 days or longer, which is associated with paroxysms, whoop, or pertussis vomiting. And we have seen this. They have a sensitivity of 81% and specificity of 58 for confirmation of pertussis. Also, you have in older children whose cough illness is escalating so fast from 7 to 10 days. Remember, after this is after the incubation period now. Symptoms start to escalate and the cough episodes are not continuous. Then also in children, like in infants less than 3 months, like we have seen, they are gagging, gasping, apneic, they have cyanosis. All right. Then you combine those features with laboratory findings of one, culture. Yeah, butane, nasopharyngeal aspirate, you do a culture, it's a gold standard. Also PCR can also be used, and then CBC, there is going to be leukocytosis, which is caused by absolute lymphocytosis. And then serology can also be used, that is, you detect the pertussis toxin, IgG antibodies in the serum. However, serology might have some limitations. For example, during the first year post-vaccination, serological testing using single serum sample does not differentiate between antibodies resulting from natural infection or those produced after vaccination. Therefore, there might be a problem in interpretation. And then also, serology should not be used in infants, as testing results are liable to interference by the maternal antibodies. So this is a summary, and they've added in a little idea on what method of diagnosis is better for a specific period of time. From here, you note there is incubation period, that is a week. Then you have the first, after the onset of cough, the first 1 to 2 weeks is catarrhal stage, paroxysmal stage, and then you have convalescent stage from 8 to 12th week. Then you have here, it's highlighted very well, the infectivity. Yeah, it's very contagious at this stage from the onset of cough up to around 3 weeks. Then you have lab diagnosis. Yeah, so from the onset of cough, you can use both PCR and culture up to around the 4th week. From the 4th week onwards, it's preferable to use serology. So how do you treat? Treatment goals here, you have to assess the progress of the disease and livelihood of life-threatening events at the peak of the disease. Then maximize nutrition, prevent or treat complication, and then educate parents in the natural history of the disease and in care that will be given at home. Remember, it's contagious. There's going to be need for isolation. That's why you have to educate these parents. So majorly under treatment should maintain fluids and nutrition, give oxygen and perform suction if the child is cyanotic, or just to clear the secretions from the mouth to facilitate air entry. Then for unimmunized or partially immunized patients, of course, you complete the immunization as per routine. Isolate the patient, avoid contact with other infants until after 5 days of antibiotic treatment. And then treatment here, macrolides are highly effective at eradicating pertussis from the nasopharynx. The recommended antibiotics are azithromycin, clarithromycin, and erythromycin. According to the guidelines I was using, you should initiate therapy within 3 weeks from the onset of cough, and you should use erythromycin 500 milligrams every 6 hourly for 7 days. Yeah. And then how do you prevent? Educate the parents on the importance of following routine childhood immunization, as this form protection from the infection, and if the child is infected, the duration, the severity of the disease is decreased. And then advise on good nutrition, avoid overcrowding since this is a contagious infection. By the time you notice that disease, because at first, like we have seen, it starts as a common cold, the features of common cold. So by the time you realize, you might have infected very many individuals. That's why you should avoid overcrowding and booster doses of vaccine in exposed infants. The complication: one, you have respiratory pneumonia. That's the onset fever symptoms. As long as fever comes in, fever is mostly not a presentation of pertussis, but when fever sets in, they're suspecting pneumonia. And then you also have emphysema, bronchiectasis, otitis media. Those are secondary infections. Then nervous system complications, you can have convulsions, coma, encephalopathy, intracranial hemorrhage. And then also you can have malnutrition due to inability to feed, dehydration. Then you have inguinal hernia and rectal hernia. These are explained in the following sentences. There is increased intrathoracic and intra-abdominal pressure during the cough, which can result into the inguinal hernias and rectal prolapse. And also some features highlighted below here. You have conjunctival and scleral hemorrhage, petechiae on the upper body, and a epistaxis, then hemorrhage in the central nervous system and retina, pneumothorax, subcutaneous emphysema, and umbilical and inguinal hernias. All this due to increased intracranial, increased intra-abdominal pressure. Thank you. In case you have enjoyed the lecture, please subscribe to my YouTube channel. Your support is highly appreciated. As we are going to summarize, this is a recap, looked at the definition, and we said this is an acute bacterial respiratory infection characterized by an inspiratory whoop following a paroxysmal cough. The clinical presentation, it's a prolonged disease which is divided into catarrhal, paroxysmal, and convalescent stages. In the diagnosis, you have cough of 14 days or longer with a whoop or pertussive vomiting, plus lab findings, that is PCR, serum, or culture of the specimen obtained by deep nasopharyngeal aspiration. The principal complications are apnea, secondary infection, that is otitis media, pneumonia, and physical sequel of forceful coughing. Thank you. Meet you in the next lecture. Enjoy your day. Those are my references.